We'll quickly run over this. GIT Pharmacology. Want to run over this a quick revision of the key concepts. Okay, so the last time we talked about this, we talked about the physiology of the stomach. I said that the stomach has some primary functions, which is what? To store food, right? To store food. Secondly, to mix the food. And the third function is to also do peristalsis, the movement of food out of the stomach in portions. So these are three major functions of the stomach. And having said that, so once there's a problem with any of those three primary functions, there will be serious complications. Now, coming from this, we look at the secretory cells in the GIT. Normally, we have the Schiff cells, the parietal cell, and the mucous cell. The Schiff cell here will secrete hormone pepsinogen, which is inactive. Pepsinogen will be combined to pepsin, which is the active form of the hormone for digestion of protein and other food substances. Then the major hormone here, the major cell here is the parietal cell, which is stimulated by acetylcholine. Now, I said this that acetylcholine will come via the cholinergic nerve fiber, the vagus nerve. So once we have it, once it's secreted, the parietal cell will secrete hydrochloric acid. Hydrochloric acid is the major, is what is responsible for the acidity of the stomach, for the pH of the stomach. So acetylcholine, histamine, and gastrin. So it means that in conditions where there is oversecretion of acid in the stomach, by blocking any of these three here, acetylcholine, histamine, or gastrin, we can reduce acid production. This is why we're looking at the physiology of the stomach, that what causes acid secretion. The first part, we talk about the Schiff cell that bring about pepsinogen and pepsin. Secondly, looking at the parietal cell, where that is stimulated by acetylcholine, histamine, and gastrin. So these stimulators will ensure that the parietal cell secretes hydrochloric acid. Hydrochloric acid here is necessary to maintain the pH of the stomach, one. Secondly, it's important to also destroy microorganisms and bacteria in the stomach. And thirdly, in a way, it also helps in digestion. Now, the third secretory cell here are the mucous cells. Mucous cells will secrete mucus. That's their function. What do we do with mucus? Mucus will also help to line the stomach to prevent from mechanical injury. Because the acid will cause wear and tear, the mucus will prevent this wear and tear. Now, we also have prostaglandin synthesis that occur. Prostaglandin synthesis here would cause the increase in bicarbonate production. Bicarbonate production would eventually neutralize acid, raising up the pH. It will also stimulate mucus. It will maintain blood flow to the GIT, which is also important, and it will inhibit gastric acid secretion. So it means that the function of prostaglandin here normally is what would prevent ulcer. The function of prostaglandin functions normally to prevent ulcer. So any activity in the body that prevents the release of prostaglandin will cause what? Would likely lead to ulcer. So we'll still come back to that. So coming back to the major stomach disorder we're looking at the GERD, gastroesophageal reflux disease, that has other function, other names, and PUD here, gastric and duodenal ulcer. Looking at this, the GERD is what I think most persons have GERD at one point or the other. So it's when it becomes too consistent that it becomes a problem. So the pulling up of the stomach contents towards the esophagus coming up. So since it is now acidic, it will cause the wear and tear of the esophagus, and that's the major problem there. The PUD, where the gastric or duodenal, just ulcer is what? Wear and tear. Once the stomach lining begins to tear or begins to break, we have ulcer. Then looking at the factors that increase acid production, smoking, alcohol, spicy foods, stress are major factors. Then we'll come to the proposed mechanism of PUD. It is, we're trying to look at how does PUD occur. What are the major, how does it occur? The first thing discussed here is this oversecretion of hydrochloric acid. So in some cases, maybe it doesn't have to be a cancer. If the body produces too much acid, it will lead to ulcer, either the gastric or the duodenal ulcer. So oversecretion is a problem. Then in this condition here called Zollinger-Ellison syndrome, so that is a pathological condition. When it says something is pathologic, so it's a disease. It becomes a disease. It is not a normal condition for someone to secrete acid to that level. So in those instances, this individual secretes too much acid. So the solution is to what? To prevent what? Oversecretion of acid in that case. Secondly, we also look at injury to the mucosal barrier, maybe from inhibition of what? Prostaglandin. So, and it said that there are drugs like NSAID or aspirin, they are major culprits that would inhibit prostaglandin synthesis via the COS1 or COS2 pathway. So, why would people take NSAIDs? You take NSAIDs to do what? To probably prevent pain, right? Inflammation and other issues. And so, either from the COS1 or COS2. So, in doing that, once you block that, you cut off all the function of prostaglandin in the GIT, bicarbonate production, mucus secretion, increased blood flow to this area, and reduction in acid secretion. So you block pain, you cause this. So that's another major factor. And the other factor here is infection by Helicobacter pylori. It is said that about 70 to 9% of PUD has this bacterial problem. So it's found that in trying to treat ulcer, it is important to verify if Helicobacter pylori is involved. Because if Helicobacter pylori is involved, you can use all the other drugs. What you have is you keep on having a relapse every 2 weeks, every month. So once there is this problem of what? Bacteria, the most important thing to get rid of is what? The bacteria. You get rid of the bacteria first, then now begin to treat the other symptoms that will ensure that you have healing. If you don't do that, the ulcer will not heal. Now, come to the goals of therapy. What is the goal of treatment here? We want to relieve symptoms. The symptoms of oversecretion, reflux disease, and all of that. You want to relieve symptoms. Secondly, you want to decrease the frequency of occurrence, because, like I said, most of us have maybe daily or weekly cases of GERD. But if it's just what happens once in a while due to some foods that we eat, it's not a problem. Once it becomes too much, you begin to bloat, and all of that, persons have to use drugs. And the third point there, so that you want to bring about the healing of the tissue. If the tissues don't heal, you still have what? Ulcer. So it is the healing of the tissue that will stop. That is when the ulcer will stop. So you want to relieve symptoms. You want to decrease the frequency of occurrence and the duration of reflux. You also want to ensure that the tissues are healed. Then, in doing this, which involve a lot of drugs, you said that a change in lifestyle is important, because by the time you look at the cause of the ulcer, changing lifestyle, maybe smoking habits, alcohol consumption, and spicy foods, and stress will go a long way in ensuring that a person stays without ulcer for the long term. Having said this, we want to look at the major drug classes that are used in treating ulcer. These are drug classes. Antacid is a drug class. And I remember we said then that antacids, antacids, what they primarily do is what? They neutralize gastric acid. We said that in nutrition pharmacology expects a drug to bind to a receptor to produce a response. And so there are a few drugs that don't bind to receptors, yet they produce what? A therapeutic effect. Antacids are one of them. They don't bind to any receptor. All they do is what? They neutralize. Acid is somewhere. You bring anti-acid there. Antacid neutralizes the acid. Once they neutralize the acid, what happens to the gastric acidity? Gastric acidity will drop. So it means that what? The pH would rise. Although it looks like a bit of an irony. Acidic pH will be from maybe 2 to 5. So in neutralizing the gastric acid, the stomach will become what? Less acidic. Once it becomes less acidic, the pH will rise. So maybe from 2 to 3, it will go towards 4, 5. It will become basic, alkaline. But it goes towards 4, 5. So that's the goal, that you want to reduce the acidic environment in the GIT that causes ulcer. And while we're talking about antacid, we said that there are many components to antacids. There are many other components. A lot of them contain magnesium, aluminium, calcium, right? So that usually is a mixture of all of this. Why? Because whereas some of them will cause constipation, some of the other ones will cause diarrhea. So you can't just have a magnesium antacid alone. That can probably cause maybe constipation or diarrhea, or aluminium alone. So it has to be a mixture of all these major components. Then we say that for persons that have maybe cardiovascular issues, those persons must be wary of antacids that contain what? High sodium content. So depending on the condition you're trying to treat, you can actually do what? Adjust. You can select the type of antacid a person, but the primary function of the antacid is what? To neutralize gastric content. So that one we must not forget that you just want to neutralize it. Secondly, we come to the coating agents too, which also don't bind to any, but it's just like they cover the ulcer craters here. We have the sucraphates. What they do is they act as a shock absorber, but just a covering, for on the ulcer, to reduce direct contact between the acid, the food, and those irritated tissues. And it must also be noted that once you're given antacid and coating agent, and you want to give other drugs, you must give the other drugs 1 hour prior or 2 hours after, because giving them together would affect the bioavailability and absorption of other drugs. So you can't give other drugs along with them because of their effect. You either give them 1 hour apart or 2 hours afterwards. So we have sucralfate there. The third point here is we're looking at the histamine H2 antagonist. Majorly we discuss histamine. So there's nothing here about histamine H2 antagonist that has to do with allergic reaction, because it's not allergic reaction. So we're looking at histamine, which is one of the primary stimulators of parietal cells to produce hydrochloric acid. So by blocking the activity of histamine agonist at the H2 receptor, we can reduce the volume of acid produced. So what histamine H2 antagonists will do is what they decrease the volume of HCl produced. So they are not neutralizing acid, but that they want to decrease volume, they deplete volume. So once you reduce volume, the stomach is expected to be what? Less acidic. So we have this. So once you decrease the volume, the gastric pH would increase. That means will rise. That is expected. So what happens? This leads to reduction of gastric mucosal irritation. And some of these drugs are cimetidine, ranitidine. For example, we have famotidine, we have nizatidine. These are the 4 major drugs. And here, we know that cimetidine is the prototypical drug here. Why? We're not saying that cimetidine is the safest drug or the most effective drug in this drug class. Cimetidine is not. But for many reasons, cimetidine is the prototypical. It's just like the drug that most persons would first of all come across. Why? Because of the number of side effects that we have with cimetidine. It's not the most effective drug here, and probably it's not even the most safest. When you consider the drug dose you're given, the number of times you have to give cimetidine in a day, as compared to other ones. Some of them are like nizatidine, some of them you can dose it once daily. We talk about, so a drug is dosed one daily and at a lesser dose, maybe 20 milligram, 40 milligram, compared to something that you're dosing at maybe 400 milligram BD. There's a wide gap there. Then we also mentioned that samethidine in men can be one of the reasons for infertility, gynecomastia, and it can affect. It can be one of the major causes of infertility in men, which some of the other drugs don't have. So the reasons why we have to be careful with samethidine, that although it's very, very common, persons will be better with maybe famotidine, zatidine, and the other. And here we also talk about the availability of these drugs, that most of them are available in oral formulations, in capsules, in tablets. Then there are some of them that have what parenteral dosage forms, depending on what you need to give the patient. So from there we move on to the proton pump inhibitors here. So what I forgot to say, so we expect that possibly with histamine H2 antagonists, it might be able to block up to 70% in some cases of acid production in the individual. So, but for proton pump inhibitors, the examples here would involve omeprazole, pantoprazole, esomeprazole, lansoprazole. Now, this class of drug, what they do is they block the formation of hydrochloric acid. How do they do this? So it is very, very similar to this in that they would reduce acid production. So these two drug class would decrease the volume of acid produced. Antacid will neutralize acid produced. Antacid would only work after acid is produced. But these ones are blocking acid production from source. So they reduce it. So why do you call them proton pump inhibitors? Because what are the protons here? Hydrogen majorly. You need hydrogen to produce acid. So this class of drug can actually reduce the availability of hydrogen for the production of what? Acid, hydrochloric acid. So invariably, it is shown that PPIs are even much more effective than histamine H2 antagonists. They are like the strongest anti-ulcer drugs you can give a patient because they block the proton pump. They block that pump. When they block that pump, the quantity of acid produced will drop significantly. So we have the examples there. Here we're looking at the prokinetic agents in the sense that what do they do? We say that these drugs are majorly used for GERD, right? In that they increase the lower esophageal sphincter, the sphincter that is just right above the stomach, that prevent the upward spilling of the GIT content back into the esophagus. So once the sphincter is in place and the normal peristaltic movement in the GIT against that wall, it doesn't push the sphincter to open up and cause the upward pulling of this GIT. So that is how people feel that irritation, that acidity. So if this is in place, it stops because there will always be that movement, peristalsis. So what we have here, this class of drug would increase lower esophageal sphincter muscle pressure. Then they also increase peristalsis. So if they increase peristalsis, it means that the tendency for the food content to move back upwards will be reduced. So it also extends the emptying of the stomach. That's what it is. So this one will be necessary in GERD, but not in ulcer. It's important in GERD, not in ulcer. So we have Reglan, metoclopramide as a major drug of choice there. The other drug here is the antispasmodic agent. Now, why do you have antispasmodics? Antispasmodics and spasm has to do with contraction or the kind of muscular contraction is a type of muscular contraction, spasm. The muscles contract and relax and move. So what do we have then here? Because we also have acetylcholine involved as one of the stimulators of the parietal cells. So antispasmodic agents will do two things. So by blocking acetylcholine, their supply to the GIT, we are going to reduce secretion. We are going to reduce all forms of secretions. We are also going to reduce motility. Acetylcholine is important in the GIT physiology, because in the parasympathetic nervous system innervations there, we need acetylcholine to maintain normal GIT function. So without acetylcholine, there may be problem with peristalsis. So in giving antispasmodics, you expect that what? There will be problem with what? Peristalsis. In also giving antispasmodics in a way to, you expect to have problems with what? Secretion. So every secretion in the GIT will dry up. That is the implication. From saliva to acid production to bile secretion and every other enzyme involved. So it blocks their secretion. For in these cases here, that's what we have. So it decreases GI motility too. Antispasmodics will decrease GI motility. Once it decreases GI motility, there may be some relief. And the major drugs here are the atropine. Atropine is an antagonist. Atropine is an antagonist. We have scopolamine, we have belladonna. So although these drugs will find more uses in other conditions, but their only use here is because of what? Reduction in secretion. Not, we don't need to reduce motility in ulcer. What we want to reduce in ulcer here or GERD is what? Secretions. So antispasmodics will not be a first line drug to be used, but for the fact that they can block secretion, maybe if there are cases where other drugs don't work well and you still need to block acetylcholine release, they could introduce this drug class. And the last drug class here will be these gastrointestinal prostaglandins. We said before that prostaglandins are necessary for bicarbonate production, mucus secretion, maintaining blood flow, inhibiting gastric secretion. So what prostaglandin does normally is to prevent ulcer. So in cases where individuals are about to use drugs that actually inhibited prostaglandin synthesis, maybe those are to use NSAIDs because they have to use it, and they have NSAIDs like diclofenac, aspirin, and all of them, and they have this. So one of the drugs that could be given them alongside the NSAIDs might be a GIT prostaglandin, gastrointestinal prostaglandin, misoprostol. So which is a prostaglandin E analog to supplement for prostaglandin. So what do we have here? We have misoprostol here. I'm sure hundreds, I think it's usually 100 to 200 micrograms, the tabs that are given. And we say that this drug is contraindicated in any woman that is pregnant or planning to get pregnant, because prostaglandin might cause spontaneous abortion. It will cause the contraction of the uterus and violent contraction. So when you have it, which will be a side effect. So a man may not have issues with cytotoxic or misoprostol because he's not trying to abort a pregnancy. But a woman that is pregnant or planning to get pregnant might have issues with misoprostol. So these are I think the first stage of discussion we had with drugs used in treating ulcer or GERD. So the major conditions we talked about here are for GERD and ulcer. Yeah, thank you.